There's nothing so close to the truth as patient material. You can't manipulate it, so you don't know what the functional relevance of anything that you find might be. So one of the things that we've been doing for some years now is actually isolating cells from tissues. And that means that you can grow them, and it means that you can take a marker and manipulate it and see what it does.
In Behind the Science, we tell the story of how innovation and infrastructure combine in Europe's leading science clusters. We understand that the places where research occurs are as critical as the research itself, which is why we reach out to the rockstar scientists to grasp not just what they do, but why they do it. Become a part of this story as we take a look behind the science.
I'm Louise Jones. I'm Professor of Breast Pathology at Barts Cancer Institute, Queen Mary, University of London, and I'm a consultant histopathologist at Barts NHS Trust. So I started off in medicine, and very importantly for me, I took a year out to do research during my medical degree. And I did that in a lab on breast cancer, and I realised that I found what I wanted to do. And then I trained in histopathology. I did a PhD, and then moved here, set up my own lab, and I run a research group here.
Is there something specifically about breast cancer that really fascinated you, or a problem that you were really interested in?
I think for me it was just how common it is. I think everybody knows somebody who's been affected by breast cancer, and I felt, with that sort of arrogance of youth, I thought, well, maybe I should come along and try and cure it, right? I haven't quite managed that, but I just feel it's very important. It's important to me as a woman, but it's important because, so many people are affected by it. I became interested actually way back, and it's work that I did my PhD on a pre-invasive type of breast cancer called ductal carcinoma in situ. And that used to be quite uncommon until screening programs started. And then we detected now represents around 20% of all cancer diagnoses. And we treat them all as though they're going to become invasive cancers. So these women might have a mastectomy, radiotherapy, they may go on hormone treatment for a long period of time. And yet we know from older studies that probably only 20% of these women would ever progress in their lifetime. The problem is we don't know which 20%. So I'm interested in discovering markers that will predict which cases will go on to progress, and therefore that we should be treating properly, and women whom really we could just put under surveillance. And I think that's really important, apart from that it's very significant treatment, you're also giving a woman a diagnosis of cancer when maybe she doesn't need that diagnosis,
How specifically are you engaging with these markers? What type of process are you going through? Talk to me more about this work.
My job as a histopathologist is looking down the microscope at tissue from patients. And I like to do a lot of work on patient material because there's nothing so close to the truth as patient material. But of course, you can't manipulate it, so you don't know what the functional relevance of anything that you find might be. So one of the things that we've been doing for some years now is actually isolating cells from tissues. And that means that you can grow them, and it means that you can take a marker and manipulate it. You can silence it, or you can activate it and see what it does to behavior of tumor cells. So we do both of those things. We work in cultures, but we also work on patient material.
And what type of technology or other systems are supporting your work?
So huge range, from immunohistochemistry, just putting antibodies onto tissues, although of course nowadays we don't use one antibody, we can use 40 all at once, which is amazing. We do quite a bit of sequencing, and more recently we have started working with collaborators applying artificial intelligence to tissues, which is a whole new world and very exciting. So what we've been doing is working with computer scientists to apply various algorithms to quantitate different features And then what we're doing is applying those to large collections of samples to see whether, when they're all combined, and that's where the power is, bringing together multiple features, whether then you can more accurately predict how that disease is going to behave.
Strikes me that there's so much power in looking at many people at the same time and that comparative ability. You've worked on a number of projects, I think, that have been pulling these types of data sets together. Can you speak a bit to that work?
One of the things that I do is run a tissue bank. So I'm one of the principal investigators of the Breast Cancer Now Biobank. And that started back in 2010, and we consent patients to donate tissue into the biobank. So we have around 120,000 samples from women with or without breast cancer at different stages that have behaved differently. And that enables us to ask very specific questions on large cohorts. I also worked on the 100,000 Genome Project. So the idea behind the 100,000 Genome Project was exactly what the title says, was to sequence 100,000 whole genomes. It focused on rare diseases, which actually also, there are so many of them, they're not very rare, and cancer. So I worked with Genomics England. So Genomics England was the company set up as the vehicle to deliver this program. But really importantly, and the reason it was so ambitious, is that it aimed to deliver whole genome sequencing on patients from the NHS. So it was like a big bang within the NHS. It was the first time we'd really brought whole genome sequencing into healthcare. And, it worked. It was amazing. It was hard, but it set up the foundation for what now is our genomic medicine service. So now patients with specific possible diseases actually have whole genome sequencing commissioned through the NHS. So it is part of a routine test. And we must be one of the few healthcare services, internationally, able to do this, which I think is kind of remarkable.
How can private industry collaborate? Are these resources open to them? Or if not, what work are you doing that also touches the delivery into the market?
Yeah, so, certainly our biobank is open to industry, and we do have commercial applications. I've recently been working very closely, actually, with a number of commercial companies, particularly around AI. And they're very interested in accessing our tissues and our images. And I think, we have a lot to gain from each other, from working together. Obviously, quite often they have a large resource, so they're able to do things much more rapidly than perhaps we can, in the public sector. But then we have a lot of expertise to give them. And, I found it very fulfilling working with commercial partners. I think we bring something different to the table, and that benefits us both.
So speaking of collaboration, there's so much activity here, and the institutions that are here are so incredibly valuable. Can you talk a bit more about the ecosystem here and what it represents both to the academic but also to the business community?
Yeah, I think ecosystem is a great word for this, right? Because we bring something different to the party, if you like. So we are Barts Cancer Institute. We're part of Queen Mary University of London, but obviously we work very, very closely with Barts Health NHS Trust, and through that there is a vehicle, the Barts Life Sciences, which is part of this East London life science cluster, if you like, which is really trying to bring together academia, the NHS, and commercial partners. And I think it's doing that really successfully. It's providing the infrastructure and the environment for us to develop those relationships, and also, the governance for us to be able to work within the regulations of our various institutes. So that's a really, really exciting development. There are others. We are part of the CRUK City of London, which brings together 4 partners. That's QM, Barts, and King's, and the Crick Institute. So very, very rich partnership. We share conferences, we share studentships. That's very exciting, actually. So, students can spend a period of time in one institute and then a period of time in another institute, picking up specialized expertise. So that's fantastic. And we, again, it promotes collaboration.
But it also feels like the time from laboratory to market is accelerating, perhaps due to these collaborations. Are you feeling that as well?
Absolutely. Probably the holy grail, if you like, in bringing a drug to market was Herceptin. It took 20 years before those drugs got into the clinic, which everybody agrees is way too long, right? And so I think this closer alignment, again, it's a triad really, isn't it? It's the NHS and our patients, it's the scientists in our universities, and it's the commercial pharma companies. I think that relationship can only accelerate these discoveries and getting them into clinical use.
You've obviously had a very productive, esteemed, innovative career. Are there any goals remaining for you that you really think, I want to get that done in the coming years?
I think what I would like to see is my research move into the clinical setting. We've been working for years trying to predict which cases of breast ductal carcinoma in situ will progress, and we're starting to put all of that information together now with the help of AI. And I would be very, very excited to be able to see that move into the clinic. And again, it seems more possible since we've started this much more joined up working between the trust, between academia and the commercial companies that are going to make this happen, actually. So that's my big goal.
Thanks for watching Behind the Science, as we've explored the power of research, collaboration, and proximity in driving world-changing innovations.